Okay, so this instrument is a Rubens insufflation cannula used to introduce dye inside the uterine cavity. So this is used for basically used for HSG, hysterosalpingography. But now the cannula that is used currently is most places is the Leach-Wilkinson's cannula. With a Leach-Wilkinson's cannula, it will look a little bit different. There will not be this red color, this thing. The Leach-Wilkinson cannula is a triangular this thing. It has got various serrations like this, right? So that is a Leach-Wilkinson's cannula. Uterine sound is also has this shape, but uterine sound will not have this blue colored stylet here. This blue colored thing here will not be present in the uterine sound, and on the other hand uterine sound will be similarly, it will be this curved instrument here, but it will have markings in inches or centimeters. They are present in the uterine sound. It will not have this blue colored stopper here. And suction cannula, this is not a cannula, this is solid. Suction cannula is a plastic material. It is made up of white in color, and definitely it is not mucus sucker. So it is anyways Rubens insufflation cannula. Even if you have not seen this, you can just eliminate it from the other options, but obviously you should know what a Leach-Wilkinson cannula also looks like, because that is the cannula used now. Rubens cannula is no longer used mainly these days. All right, now moving on to the next question. Question number 38, let's see question number 38 here. Misoprostol has been found to be effective in all of the following except. The answer is menorrhagia. Misoprostol is used in missed abortion also. In missed abortions, misoprostol can be given to induce abortion. Induction of labor, misoprostol is also used, and prevention of PPH also misoprostol is used. There it is given, recommended by WHO in a dose of 100 microgram orally. This is the recommendation by WHO for prevention of PPH. Misoprostol is used in this dose. Menorrhagia, misoprostol is not used. So I just want to give you here what are the drugs which are useful for menorrhagia. Drugs which are useful for menorrhagia. Alright, just note down the drugs that are useful for menorrhagia. Usually let us begin with NSAIDs. We can give NSAIDs which are effective, which can give mefenamic acid is usually the one which is given, right? But NSAIDs, they are not given for coagulation factor disorders. Remember that. If there are coagulation defects, then NSAIDs are not given. Then this is not for coagulation defects. But coagulation defects are not that common, so anyways we can give NSAIDs. We can give tranexamic acid. Then we have our oral contraceptive pills. Then we have progesterones. Now progesterones can be given in many forms. They can be oral progesterone, they can be Mirena, which is intrauterine system, so any oral or Mirena. Now what progesterones can be given? What are the progesterones which are given? The progesterones which are available, we commonly use, one is the medroxyprogesterone acetate. Okay, one is the medroxyprogesterone acetate, the other is norethisterone, and these are the usual progesterones that are used. And then Mirena is an LNG, levonorgestrel containing IUD, that can be used. GnRH analogues can be used. They will be the last resort. So these are the drugs which are used. Very importantly, many times it is asked that all these are proven and found to be beneficial for the treatment of menorrhagia, but not ethamsilate. So we do not use ethamsilate. Alright, we do not use ethamsilate. That is an important point to remember here. Alright, now let us move on to the next question. Question number 39. Alright. Ovaries develop from which of the following? Ovaries develop from genital ridge. A. There is no discrepancy here. Mullerian duct give rise to the uterus and other structures. Endoderm of the urogenital sinus gives rise to the part of vagina. Genital tubercle takes part in the formation of the external genitalia. So let us just talk about the development of the female genitalia. All right, let us just talk about the female genital development. Okay, and the important points, we will deal with the important points here. So if we talk about external genitalia, all right, the genital tubercle gives rise to the clitoris, right? And in the male, let's talk about the females first. So genital tubercle gives rise to clitoris, genital swelling gives rise to the labia majora, and the primitive urethral fold gives rise to the labia minora, right? Then in the males, the genital tubercle give rise to the glans penis, the genital swelling or this counterpart of labia majora is the scrotum, and that of minora is the ventral aspect of penis, penile urethra. All right, so this is what the external genitalia develops from. Labia majora, let us just see the important points about labia majora. The labia majora, it joins posteriorly, labia majora joins posteriorly at the posterior commissure, and the labia minora joins posteriorly at the fourchette. Right? So this is an important point to remember here. Then some important points about the labia majora. Some important points about the external female genitalia. Okay, you should remember that the labia majora round ligament, the round ligament terminates at its anterior end. This is one very important point to remember, that the round ligament terminates at the anterior end of the labia majora. Another important point to remember is about labia majora is that hydroadenoma of vulva, it is a benign tumor. It arises in the labia majora, not in the labia minora. This hydroadenoma is a benign tumor of apocrine sweat glands, and it is found in the majora, not the minora. Very, very important point, the sensory innervation. The sensory innervation of the vulva is from three sources. The antosuperiorly, it is from the ilioinguinal and genitofemoral nerves, and both of these branches are branches of the lumbar plexus. That is the important point to remember. Then postero-inferiorly, they are supplied by the posterior cutaneous nerve of thigh, which is a branch of the sacral plexus, and then pudendal nerve, which again a branch of the sacral plexus. So nonetheless, the anterosuperior portion is supplied by branches from the lumbar plexus. That is an important point to remember about the sensory innervation of the external female genitalia, right? Similarly, the lymph node innervation is also very important, the lymphatic drainage of the vulva, because questions pertaining to that also are asked. The lymphatic drainage of the external genitalia or vulva is also very important. You have to remember that the midline structures, important point to remember, the midline structures like the clitoris and the labia minora, example the clitoris and the labia minora, they have bilateral drainage. Okay, they have bilateral drainage, and the lateral structures, or more importantly like the labia majora and much lateral, they have unilateral drainage or same sided drainage or ipsilateral. Let's better term would be ipsilateral drainage. And where is the drainage? Lymphatic drainage of the vulva is to the superficial inguinal lymph nodes, from the superficial inguinal to the deep inguinal lymph nodes. The most superior part of these deep inguinal lymph nodes, the most superior part is the Clockett's lymph node, or it is also called as the lymph node of Rosenmüller. Okay, these lymph nodes, they are located, these deep inguinal lymph nodes are in the femoral canal, isn't it? Then from the deep they go to the pelvic lymph nodes. Okay. Similarly, some clitoral lymph nodes, some lymph nodes from the clitoris, not all, some clitoral lymph nodes can go directly to the deep inguinal lymph nodes, not all. Okay, so mainly it is superficial inguinal, then deep inguinal, and then pelvic lymph nodes. The clinical significance of this lymphatic drainage is in the management of CA vulva. So what is the clinical importance for this? That whenever there is carcinoma vulva, CA vulva, and CA vulva, for example, if it is a clitoral growth, okay, if it is a clitoral growth, central midline growth, example, a midline growth which is within 1 centimeter of midline, whenever it is within 1 centimeter of a midline, then what is done? The treatment or the surgery involves dissection, radical dissection of tumor, and bilateral inguinofemoral lymphadenectomy. And for example, if it is a growth or tumor in a cancer in the labia majora, example, if it is involving the labia majora, then radical dissection will be followed by ipsilateral inguinofemoral lymph node dissection. Okay, that is the difference. That is the clinical significance, that whenever there is CA vulva, or there is a clitoral growth, or there is a midline growth within 1 centimeter of midline, the treatment involves radical dissection of the tumor and bilateral inguinofemoral lymphadenectomy. This was the latest question which was asked in the latest AIMS question, the last AIMS paper. This question was asked on CA vulva, had not been asked for quite some time in the PG entrance examination, but this time CA vulva resurfaced, and this was the question that was asked. So again, this is very, very important, and you have to remember that this question could be attempted simply if one was aware of the lymphatic drainage of the vulva. This question could be attempted there as well. Or if it is a growth which is involving the labia majora, this is a lateral structure, then the treatment is radical dissection and ipsilateral inguinofemoral lymph node dissection. Okay, so this much you should understand about the lymphatic drainage of the vulva. Next, let's talk about the development of the uterus. We will talk about the development of the uterus and the vagina. Okay. Now, as far as the development of the uterus and the vagina is concerned, the uterus and part of the vagina are developing from the paramesonephric ducts. All right. So, what is important to remember is that there are certain male structures and certain female structures which are developing from these guts, from these ducts. So, there are two ducts which we have to talk about. One is the paramesonephric duct and one is the mesonephric duct. All right. So, it is the paramesonephric duct which fuses in the midline to give rise to this uterus and part of the cervix and part of the vagina. Vagina is on the other hand developing from two sources. Vagina on the other hand develops from two sources, all right. This is the ovary, these are the tubes. Now ovary is developing from the genital ridge. This is the genital ridge, ovary is developing from the genital ridge. This is the paramesonephric duct. Paramesonephric duct or the Mullerian duct, which is giving rise to the female genital tract, right? And this is the fused paramesonephric duct in the center. Then there is another duct which is there, which is traveling there. There's another duct which is traveling there all through this while. This is the this was initially the paramesonephric duct is lateral, then it turns medial, and this is the mesonephric duct. So mesonephric duct and its remnants, mesonephric duct as you can see keeps running and then it disappears. This is the Wolffian duct. Alright, so mesonephric duct was initially medial to the paramesonephric duct. Later on, once the paramesonephric duct crosses over and comes to the midline to fuse together, then what happens is that the mesonephric duct remains lateral for the rest of the way, and ultimately it is going to disappear. That is why shown by the dotted line. So we are concerned with the paramesonephric duct. So what you have to remember, the important points that you have to remember is that both ducts are present at 6 weeks of gestation. Both ducts are present at 6 weeks of gestation. Then the paramesonephric ducts, paramesonephric or the Mullerian ducts, they fuse to form the uterus, at around 10 weeks of gestation. Question has also been asked that when does the corpus and the cervix differentiate? That also happens by 10 weeks, right? Important point to remember is that this fusion occurs first in center and then proceeds cranially and caudally, okay? So this fusion happens first in the center, then proceeds cranially and caudally. Then the other important point to remember is that once this fusion happens, the septum has to develop, or the cavity septum has to dissolve. The septum that is there in between, that dissolves caudally to cranial, okay? So this dissolution of the septum happens from caudally, from below upwards, in other words from below upwards. And another important point to remember is that the uterine cavity is formed by 18 weeks and the end, so cavity is formed, the septum dissolves and the cavity is formed completely by 18 weeks and the endometrium is formed by 20 weeks. So these are the important time sequence events to remember in the development of the uterus. All right. As far as the vagina, as far as the vagina is concerned, the development of the vagina is from two sources. Let us see the development of the vagina. When we talk about the development of the vagina, we should remember that partly develops from the Mullerian duct, okay? So there is the fused Mullerian duct which are coming, right? And then this is the endoderm, primitive urogenital sinus. This is the primitive urogenital sinus, onto which will develop into the bladder and the rest of the vagina. So what is happening? This is the fused these are the fused Mullerian ducts which are coming down, and then swellings in the primitive urogenital sinus appear. This is the sinovaginal bulb. These are the sinovaginal bulbs which make this area into this primitive urogenital sinus into a solid plate, right? So you see that this sinovaginal bulb is originating from the primitive urogenital sinus. This is also endodermal in origin, okay? This is also endodermal. And here somewhere between the sinovaginal bulb and the rest part of the primitive urogenital sinus, this is where the hymen develops. And so what is important to remember, this hymen develops how? Because this part of the sinovaginal bulb, this part is to canalize, okay? This part has to canalize, and this canalization takes place at around 20 weeks of gestation. And failure to canalize leads to a defect called as transverse vaginal septum. Alright, this is transverse vaginal septum, and such kind of women who will have a transverse vaginal septum will have this failure to canalize. They will have this varying thickness of transverse vaginal septum. They will present as amenorrhea. Okay, present as amenorrhea. But what is important to remember is that hymen develops here after the canalization of the sinovaginal bulb, this persistent membrane, that is the hymen, and hymen develops on both sides of the hymen. There is endoderm. So very important point, hymen is lined by, very important point, hymen is lined by stratified squamous epithelium on both sides, okay, because it is developed from, or in other words, there is endoderm on both sides. So hymen is lined by stratified squamous epithelium on both sides. Alright, sometimes this hymen can be imperforate, and that it leads to, again it will present an amenorrhea. Sometimes there can be an imperforate hymen, and an imperforate hymen will also present as amenorrhea. Alright, so this is how the vagina develops. So development of vagina ultimately is from the Mullerian duct, and it is partly from the urogenital sinus. So both it is mesodermal as well as it is endodermal. Okay, so these are the important points to remember in the development of this thing. So what did we see? Let us just outline the ducts and the various structures it gives rise to, because that is again an important point. So we have the females here, and we have the males here, and let us talk about the ducts. We have the Mullerian duct. Now the Mullerian duct in females give rise to the tubes to the uterus, tubes to the uterus, cervix, right, and the upper part of vagina. In the males, the Mullerian duct regresses to form the appendix of testes and prostatic utricle. Similarly, we have the Wolffian duct. Wolffian duct in the females, you remember that Wolffian duct is the major duct which forms structures in the males, and the males, the Wolffian duct forms the epididymis, the vas deferens, seminal vesicle, and ejaculatory duct, right? They are formed by the Wolffian duct. In the female, the Wolffian duct regresses to form the apo-oophoron, the para-oophoron, and the Gartner's duct, right? Now this important point to remember is that this para-oophoron is one remnant which is located in the medial part of broad ligament. Okay, this is located in the medial part of the broad ligament. Rest, these two, apophoron and the Gartner's duct, they are remnants on the lateral part of broad ligament. Okay, question has been asked on this, where is this para-oophoron located? So this is an important point to remember. Then another question that they have asked is, from where does these, so this you can see, realize that these are the Mullerian duct structures, these are the Wolffian duct structures. Important point is where does the round ligament develops from? So round ligament, important point, round ligament and your ovarian ligament, both of these two ligaments, they are derivatives of the, they are derived from the gubernaculum. Okay, they are remnants of the gubernaculum. Again, important point, round ligament, ovarian ligament are not developed from these ducts, they are derived from the gubernaculum. Alright, so these are important points to remember about the development of the male and female genital tract. Now, similarly, another important point to remember about the male and female development and the disorders of sexual development, because that flow chart that I am going to give you right now is going to help you solve many questions regarding disordered sexual development. All right, so what we have to understand that why this Mullerian duct develops in females and why it disappears in the males, or why Wolffian duct develops in males and disappears in the females. This is a prime question. So let us just go through this flow chart here about the development of gonads. The development of gonads, you can understand we are talking about the development. Now we are talking about the development of gonads. So first of all, you have to remember that initially these gonads are bipotential gonads. Gonads are developing in the genital ridge. They are in the genital ridge. They are bipotential. Both testes and ovaries will develop from the genital ridge. They are bipotential at 5 weeks of gestation. To these bipotential gonads come the germ cells, right? So the primordial germ cells, they originate not in the gonads but in the epiblast, right? They originate in the epiblast. They are ectodermal in origin. From the epiblast, they come to the yolk sac at around 2 weeks of gestation. From the yolk sac, they move on to the, genital ridge. They move on to the genital ridge at around 6 weeks of gestation, right? And after that, the genital ridge, when these primordial germ cells, they reach the genital ridge, that is when the genital ridge development further takes place. All right. So moving of the primordial germ cells to the genital ridge then stimulates the rest of the differentiation of the bipotential gonads, right? So what happens whenever there is an XY, whenever there is a fetus whose genotype is XY, whenever there is an XY genotype, this XY genotype person has what? It has a sex determining region on the Y chromosome. On the short arm of Y chromosome is the sex determining region, and this SRY, it acts along with SOX gene and additional genes for which you have to know the name, steroidogenic factor and fibroblast growth factor 9. All these genes, you have to remember the names. Very, very important. It is SRY and SOX gene. Whenever this happens, whenever there is upregulation of the products of these genes, okay, this arm is upregulated, and that leads from whenever there is XY genotype, the SRY gene is upregulated on the Y chromosome, that further upregulates the cascade of other genes, which is SOX gene, SF1 and fibroblast growth factor 9, that leads to formation of the development of the gonads at testes. These testes, they synthesize Sertoli cells, right? So Sertoli cells are the ones that begin synthesis first. Sertoli cells development by 7 weeks, they start synthesizing anti-Mullerian hormone. As the name suggests, in the presence of anti-Mullerian hormone, the Mullerian duct regresses. Okay, the Mullerian duct regresses. With the testes, again, then the Leydig cells develop, and the Leydig cells, they start secreting testosterone. They start secreting testosterone by 8 weeks. Another important point. Question was asked, when is testosterone secreted? It is secreted at 8 weeks. And the maximum is secreted at around 15 to 18 weeks. Okay, between 15 to 18 weeks is the testosterone secretion maximum in the fetus, in the male fetus. So Leydig cells develop later. Then the Sertoli cells, they start secreting testosterone by 8 weeks. In the presence of this testosterone, 2 things happen in the presence of this testosterone. One is One is that this testosterone is going to lead to development of the Wolffian duct. Okay, Wolffian duct develops, and the other thing that happens is that this testosterone, in the presence of the enzyme 5-alpha reductase, gets converted to DHT, which forms the external genitalia of the male. DHT is dihydrotestosterone. All right. So what do we understand from here? We understand that for external genitalia to become masculinized, we need DHT, not just testosterone alone. And we understand that all these events have to take place in synchronicity. All right. So what happens? Sometimes there have been asked questions. They've been asked that whenever this genotype is not XY, or there is a defect here in this level, then the gonad genotype, despite being XY, the gonads will not form. The gonads will not be testes, right? Similarly, testes might be producing testosterone, but if there are no receptors for testosterone, then the testosterone will not act and further development will be stopped. So despite the gonads being testes, the person with the gonads becoming testes, but testosterone is not able to act, the Wolffian duct will not develop, the external genitalia will not masculinize, and they will get something which is called as androgen insensitivity syndrome. Similarly, if AMH is absent, certainly cells are not synthesizing AMH, there is a defect in this limb, then rest of all of the development proceeds fine. All right, that means the gonads develop as testes, and then the internal genitalia is also male and the external genitalia is also male, but somehow the Mullerian duct structures do not regress, and that leads to Mullerian hernia syndrome, uterine hernia syndrome, where there is persistence of the Mullerian duct structures. So I want you people to remember this flow chart, that will help you remember the various complications that can arise out of this thing. All right. Similarly, if there can be a 5-alpha reductase deficiency, if there is a 5-alpha reductase deficiency here, right, then if there is a deficiency of 5-alpha reductase enzymes here, then what happens? The external genitalia does not masculinize, but the gonads are testes, they form testosterone. So for all practical purposes, the person is a male with internal genitalia of male, but just born externally looking like a female. All right. So those kind of problems can be there, and these enzyme defects can be there, and so questions can be framed on this. They have been asked on this sometimes. All right. So that is why understanding this flow chart is very, very important about the gonadal development. So this, we talked about the male development of the gonad. What about the female development? Whenever there is absence of SRY, whenever there is absence of SRY, that means whenever there is XX, okay, there is no SRY because SRY is present on the Y chromosome. Both X's are required, for complete ovarian development. Okay, complete ovarian development. Okay, that is why remember that in Turner syndrome, when the karyotype is X, so we have streak ovaries. Okay, ovaries start developing but they don't mature properly, so they have streak ovaries. So whenever the gonads are, whenever the genotype is XX, what happens? That there is certain other somatic genes which the name you should remember, WNT4 at least you should remember, R-spondin1 you should remember the name, and you should remember DAX1. These are the names that you should remember. These genes are upregulated, they are upregulated, and what happens? The gonads become ovaries. So initially it was thought that the development of the ovaries is a passive process. Mere absence of SRY does not result in development of ovaries. These genes have to be present and they have to be upregulated. So in when the gonads become ovaries, these ovaries in the fetal life, they do not secrete much of any hormones, unlike the fetal testes which are synthesizing AMH and testosterone, right? So there is no testosterone. So since there is no testosterone, what happens is that the Wolffian duct regresses, and since there is no AMH, what happens is that the Mullerian duct develops. Right. So this is what is important to remember about here. All right, so this is what is important and it should be remembered. So right now I just want to talk about two important conditions here, and I want to talk about them side by side. One is the pure gonadal dysgenesis. One is pure gonadal dysgenesis, and one I want to talk about. Let me just write it again. Two conditions side by side I want to talk about. One is pure gonadal dysgenesis and one is androgen insensitivity syndrome. I want to talk about them side to side because right now when I talked about that flow chart, here these are the two conditions I wanted to talk about. In pure gonadal dysgenesis, it is usually seen that the genotype is XY, but the gonads are dysgenetic. There are no gonads developing. That means the defect is here somewhere. That is pure gonadal dysgenesis. And androgen insensitive syndrome, the defect is here where the testosterone is being secreted, but there are no testosterone receptors, so testosterone is not acting. All right. So let me just give you here the brief about these two conditions, pure gonadal dysgenesis and androgen insensitivity syndrome. Pure gonadal dysgenesis, when it is 46XY, there can be 46XX pure gonadal dysgenesis, all right, also. But when it is 46XY, then it is called as Swivers syndrome. All right, this is called as Swivers syndrome. Remember, in the Swivers syndrome, the gonads, there is Y is there, but the Y has no SRY. Remember that this Y has no SRY. This Y has no SRY. Some problem with the Y having SRY. So what happens? The gonads, they do not become testes. In fact, they become dysgenetic. There are dysgenetic gonads. These dysgenetic gonads, they do not secrete anything. All right. So because they do not secrete anything, what happens? That the internal genitalia is that of female because there is no AMH. Secondly, the external genitalia is that of female. Y is also female. Why? Because there is no testosterone, right? So female, importantly female, internal genitalia, external genitalia, both female. All right. Wolffian ducts are not developing. Wolffian ducts don't develop. Wolffian ducts, they also don't develop because there is no testosterone. So for all practical purposes, these are female with dysgenetic gonads and genotype XY, but they are raised females, right? They usually have they will have amenorrhea, and because these dysgenetic gonads will not secrete estrogen, they will have absence of breast development. They will have no breast development because there is no estrogen in their bodies, right? What is important to remember is that they will have normal height. They will have normal height. They will have absence of breast development, they will have amenorrhea, right? And they will have a uterus, all right? So what is important to remember, important points to remember is that the only problem that they have is amenorrhea and absence of breast. So the treatment will be that they will need estrogen plus progesterone replacement, all right? Pubertal induction they will need, plus they can get pregnant by, can get pregnant by oocyte donation, okay? So they can get pregnant by oocyte donation. They can take other person's oocyte and that can be, and then get pregnant with that. Okay, another important point is that these dysgenetic gonads, they need to be removed. So important point is that gonadectomy is required in these females because there is risk of gonadoblastoma, there is risk of malignancy in these dysgenetic gonads, and these gonads need to be removed as soon as diagnosis is made. This is in contrast to the gonadectomy that is required in androgen insensitivity syndrome, because in that the gonadectomy is done once the pubertal development is complete. Talking about androgen insensitivity syndrome, let me just give you a brief that this is the most common cause of male pseudohermaphroditism. Okay, this is the most common cause of male pseudohermaphroditism. The genotype is XY. The gonads are testes. All right, the gonads are testes, and these testes, they are producing testosterone. So what happens is that the testosterone is being produced, but there is no testosterone receptors. There is no testosterone receptors. There are no testosterone receptors. So the internal genitalia, the Wolffian ducts and everything does not develop. Okay, the Wolffian duct doesn't develop. The external genitalia also does not masculinize in the absence of testosterone being so the external genitalia is female. Okay, and the other important point is that the AMH is present. In this case, the testosterone, the testes, gonads are testes. They are secreting testosterone, but testosterone receptors are not there. There are no receptors. These testes, they also secrete anti-Mullerian hormone. Okay, since they secrete anti-Mullerian hormone, the Mullerian duct regresses. All right. So in them, what is happening? In them, these are females. These are born females, these are raised as females, right? They present with amenorrhea. Once they present with amenorrhea, what happens is that we realize that their Mullerian duct structures are absent. So in them the uterus, the tubes and the vagina is absent. Okay, in these are absent in these females, they are absent. There can be a vaginal pit from the endodermal origin source of the vagina, that can be a vaginal pit, right? And very importantly, they will have breasts are well developed. They will have well developed breasts. Their height is normal. Okay, they have well developed breasts, their height is normal, and importantly, very importantly, the pubic hair are absent, because these hair are androgen dependent hair, and pubic hair are absent importantly because they are androgen dependent hair. So pubic hair are absent, breasts are well developed, height is normal. What is important to remember in this is that these gonads, again testes, they are prone to malignancy and gonadectomy is required, but in androgen insensitivity syndrome, the gonadectomy is done after pubertal development is complete, after puberty is complete, or at the age of 16 to 18 years. All right, why? Because these gonads, they are secreting, the gonads are secreting testosterone, and this testosterone is getting converted to estrogen peripherally, right? And this is contributing to the gonadal development or the breast development in such females. All right, so gonadectomy is done, but it is done after puberty is complete. And second important fact is, once you remove these gonads, they will the pubertal development is complete beyond that point, and then after that they do not need any estrogen replacement, because they will need estrogen replacement, yes, to maintain them as females further on, right? And important point to remember here is that they have the poorest reproductive outcome. They have the poorest reproductive outcome. Okay, they have the poorest reproductive outcome, because for them they have no gonads. They have, the gonads are testes which need to be removed, and they are raised as females. So adoption is their only option. An important point in their management is to let them be females, right? Sometimes there's a question asked that, is the phenotype always female? Is the phenotype always female? Then sometimes this is a false statement. Why? Because sometimes there is a case of partial androgen insensitivity syndrome or incomplete insensitivity syndrome, where there can be ambiguous genitalia. Okay, where there can be ambiguous genitalia. That is why the blanket statement that phenotype is always female is false statement. There can be partial androgen insensitivity syndrome where there can be ambiguous genitalia. All right, so this is important about Swyer syndrome and androgen insensitivity syndrome, two important syndromes that we should understand. All right, let us move on to the next question. Question number 40. All of the following are known risk factors for the development of this disorder except. Now the answer to this question is, first of all, let us see what is happening in this question. There is some cancerous growth which is involved in, there's some growth and hyperplasia that is happening in the endometrium, and then this endometrial cancer. So what we are talking here, this figure is representing endometrial cancer, and endometrial cancer, this is endometrial cancer, and the risk factors are all except early menopause. All right, early menopause is not a risk factor. What is a risk factor is late menopause is a risk factor. All right, so very important when we talk about risk factors for these various cancers. All right, oncology, gynae cancers is a very important topic. What is important is the risk factors, the stage-wise treatment. Staging is very important because direct questions on staging are asked. The risk factors, the staging, the stage-wise treatment, the post-therapy treatment. CS cervix is very important. They have asked about CS cervix management even in pregnancy. So all these cancers are very important. So I will give you these important bits about gynae oncology as and when the question comes, and the important points thereof. So let us now discuss just one flow chart here for you people to remember the risk factors for gynae cancers. Okay, risk factors for gynae cancers. When we talk about the risk factor for gynae cancers, let's talk about endometrial, ovarian and cervical. Okay, these are the three main cancers where we're going to talk about risk factors, and both endometrial and ovarian cancers, the risk factors are the same initially, right? Which risk factors are the same? Your early menarche, okay, late menopause and nulliparity, right? These are same, and these are not risk factors for cervical cancer. In fact, multiparity is a risk factor for cervical cancer. All right, all right, so this is how we remember. Other important risk factors for endometrial cancer is infertility. Infertility is one. Unopposed estrogen. Unopposed estrogen in any form like PCOS with anovulation. Estrogen containing HRT if they are given, right? Tamoxifen. All these can lead to unopposed estrogen exposure and lead to endometrial cancer. All right. Other important point. So this is about unopposed estrogen exposure being a cause. Then the other risk factors, there is a risk factor very important with ovarian cancer. There is a called as a corpus cancer syndrome. Corpus cancer syndrome is a triad which consists of diabetes mellitus, hypertension and obesity, right? So obesity is a risk factor for ovarian cancer, diabetes mellitus is a risk factor, but if you say hypertension, hypertension independently is not a risk factor, all right, but hypertension is a part of this triad. Diabetes mellitus, obesity, they are risk factors, but hypertension is independently not a risk factor. All right, so one thing is this. Secondly, smoking. Smoking is a risk factor for ovarian cancer. Smoking is a risk factor for ovarian cancer for the mucinous histology. Smoking is also a risk factor for cervical cancer. Okay, so smoking is a risk factor for cervical cancer, and for smoking here it is risk factor for this squamous cell type of ovarian of cervical cancer. All right, so we have come to smoking, and smoking being the risk factor for ovarian and cervical cancer, where you have to remember that smoking is protective for endometrial cancer on the other hand, right? So we have smoking here as risk factors. What are the other risk factors for cervical cancer? Multiparity, smoking, STDs, multiple sexual partners, right? Early intercourse, early childbirth, low socio-economic status. All right. So what we remember is that for cervical factors, what are not risk factors, which are there with ovarian cancer. For cervical factors, early menarche, late menopause, nulliparity, and family history. And family history is not a risk factor. So we remember for cervical cancer, early menarche, late menopause, nulliparity, and family history. Family history is not a risk factor for cervical cancer. You getting my point? Similarly, let us just continue the table further. We're talking about endometrial, ovarian, and cervical cancer. So we see that for endometrial cancer, smoking is protective, whereas smoking is a risk factor, and for both this thing, ovarian and cervical cancer. Similarly, apart from smoking being protective, OCPs, oral contraceptive pills, they are protective. For endometrial cancer, OCPs are protective. For ovarian cancer, but OCPs are a risk factor for cervical cancer and the adenocarcinoma. There is a risk factor for adenocarcinoma. That also you have to remember. So OCPs are protective. OCPs are protective. Smoking is protective for endometrial cancer. It is a risk factor for ovarian cancer. Other important points, what other factors are protective for endometrial cancer? Multiparity is protective for endometrial cancer. Green tea, phytoestrogens, just to complete the list, these are protective. With ovarian cancers, what is protective? Apart from OCPs, the other things that are protective is again multiparity, salpingectomy, hysterectomy, tubal ligation. These are thought to be protective. Breastfeeding is thought to be protective. All right, so all these factors are considered protective factors for ovarian cancer. Cervical cancer, on the other hand, has no such protective factors. It has only got risk factors. Even OCP is a risk factor, right? Then we come to the hereditary component of these cancers. If we talk about the hereditary component of endometrial, ovarian, and cervical cancer, if we talk about the hereditary component, the hereditary component is present in endometrial cancer, present in ovarian cancer. There is no hereditary component here. There is no hereditary component in cervical cancer. In endometrial cancer, HNPCC, that is the Lynch 2 mutation, is more important than the BRCA, right? And with HNPCC, there is a 75% lifetime risk of having endometrial cancer. With ovarian cancer, there is BRCA mutations are more important than HNPCC, right? Anyways, the lifetime risk with BRCA1 and BRCA2 and with HNPCC, right? The lifetime risk of ovarian cancer. The lifetime risk of ovarian cancer with BRCA1 is about 45%. With BRCA2, it is 25%, and with HNPCC, it is around 15%. All right. Then another important one-liners that are important as far as ovarian cancer is concerned is the baseline lifetime risk of ovarian cancer is 1 in 70, that is around 1.4%, with one first degree relative, right, and with two first degree relatives, this risk of 1.4% goes to 5%, and with 2 first degree relatives, this risk goes to 7%. What is important when I'm talking about this, I'm talking about the familial Familial, all right. Familial is not the same as hereditary. Hereditary is something which is transmitted by these mutations. Familial is what is something which is just running in the families, might not have a hereditary component to it, so that is different, all right. So this is about, this important little flow chart helps you cover the important risk factors, all right. So most of the times the questions are going to be asked like all of the following are risk factors except, or what are the risk factors, what are the protective factors. So if you read them all together about as far as like endometrial and ovarian versus cervical are concerned, then you help them, it helps to remember better, all right. Now let us move on to the next question. Question number 41 we have discussed already. Okay. Now we have the next question here. The next question is the most common pure germ cell cancer. The most common pure germ cell cancer of the ovary is dysgerminoma. Dysgerminoma is the most common pure germ cell cancer of the ovary. All right. So let us just see what are the important ovarian cancer types. Ovarian cancer one-liners, just let us remember just a few little things. So you have to remember that overall ovarian cancers are most commonly, they are epithelial in origin, okay, overall epithelial. And so overall the most common ovarian tumor can be benign or malignant. So overall most common ovarian tumor can be benign or malignant. So just let us go one by one. If we talk about ovarian masses, let's talk about not even cancer, we're talking about ovarian masses. Let's talk about ovarian masses. Overall, the most common ovarian tumor, most of the ovarian tumors are epithelial. All right. Tumors can be benign or malignant. Most of these epithelial tumors are benign, right? So overall, most common becomes serous. Among the epithelial, the most common histology is serous, okay. So among the epithelial ones, there are many histologies. We have serous, we have mucinous, clear cell, endometrioid, and a host of other histologies. But the most common histology is serous histology. So the most common becomes serous cyst adenoma. Okay, serous cyst adenoma, which is benign. Alright, so this is the overall most common ovarian tumor, epithelial. If they ask specifically the most common ovarian tumor can be benign or malignant in reproductive age group, okay, or in pregnant female, both are the same reproductive age group, or in pregnant female, either of the things, then the answer is tumor, benign. Benign is any times more common. Benign, then that is a dermoid cyst. The answer to this is a dermoid cyst, which is a benign cystic teratoma. Right? Now, the other important question is so we realize that the most common ovarian tumor in reproductive age groups is a dermoid cyst. Dermoid cyst is a germ cell tumors. So in other words, it can be also be, the answer could also be a germ cell tumor. The option could also be a germ cell tumor, all right. So germ cell tumors are more common in the reproductive age group, all right. Now, most common, next important point, most common ovarian cancer. Now this is cancer in reproductive age group or in pregnant female, okay. So in reproductive age group, if there is an ovarian cancer, in reproductive age group, it is going to be again germ cell type. Now we're talking about cancer, so the answer here is dysgerminoma. Alright, the answer here is dysgerminoma. Alright, now certain other important pointers. Most common ovarian cyst is a benign follicular cyst. Alright. Most common ovarian cancer to metastasize to opposite ovary, that is a granulosa cell tumor. Right? Similarly with ovarian cancers, a lot of time, these questions are asked like the histopathological features. Alright, let us just see what are the histopathological features. The histopathological features of various ovarian cancers. Let us just summarize the histopathological features of various ovarian cancers, because questions are again asked on this. So we have the most common type histology is epithelial. Again, in epithelial we have serous histology. So we have the serous epithelial type. The serous epithelial type of ovarian cancer has psammoma bodies. Okay, psammoma bodies. Then we have the Brenner's. Importantly, Brenner's is a type of epithelial type. Okay, Brenner's is a type of epithelial type. This Brenner's has transitional epithelium and it has Walther cell nests. Remember, it has coffee bean nuclei, and this is a solid tumor, and it is also associated with pseudo-Meeks syndrome. Okay, very, very important point. Next important is your germ cell tumors. All right, the various germ cell tumors. We have your endodermal sinus tumor. So one is this, second is Brenner's, third is an endodermal sinus tumor. Endodermal sinus tumor is a germ cell tumor, also known as the yolk sac tumor. This is also malignant, and it has the Schiller-Duval bodies. Then we have the next type. We have the Leydig cell tumor. It is also called as the Hylas cell tumor, and that has the ring-case crystals. Ring-case crystals are seen in the Leydig cell tumor. Secondly, we have the Rokitansky protuberance. Rokitansky protuberance is seen in the dermoid cyst. And then we have the signet ring cells. These signet ring cells are seen in the Krukenberg's tumor, which are metastatic tumors. So these are about the various histopathological features of ovarian cancer. So some important ones which you should remember, simple one-liners can be asked on this, have been asked on this. And then we come on to the markers, the various markers of ovarian cancer. So when we talk about epithelial ovarian cancer, and especially the serous type, the marker is CA125. Now this CA125, important point is to remember that it is of little use in premenopausal women. It is of little use. It is not very specific. It is of little use in the reproductive age group female, because there are many conditions, benign conditions, which lead to increased CA125 levels, like endometriosis, fibroids, pelvic inflammatory disease, and other cancers which can lead to raised CA125 levels. So it is not very specific in reproductive age group, but it is very sensitive and good marker in postmenopausal women. Okay, so whenever there is a postmenopausal woman with an enlarged ovary or with an ovarian mass, CA125 level should definitely be estimated, all right, because it is a very good marker in case of postmenopausal women. CA125 level should be done. Why do you want the CA125 level? Ultimately, whenever there is a postmenopausal woman with an ovarian mass, most of the times, you know, the surgery will have to be done, because ovarian masses in postmenopausal women cannot be ignored. But CA125 level does not serve any diagnostic purpose. What it does is to give us a baseline level of CA125, so that after surgery we have something, we can follow up on these CA125 levels to see that whether they have subsided, they have disappeared, or they sometimes reappear in cases of recurrence. So CA125 levels, they do not have a diagnostic significance. They just have significance whenever the mass is doubtful, whether it is benign or malignant, or whether we are planning a conservative treatment, or when we are following up after surgery. That is when there is importance of CA125. So we should remember that CA125 is a marker for epithelial ovarian cancer, that to serous histology. It is a very good marker in postmenopausal women, and it is not specific in the reproductive age group. Another important point is for the mucinous histology. For the mucinous histology, the marker is not CA125, it is CEA or CA19-9, okay. This is another important point. So CEA, carcinoembryonic antigen, is the marker for the mucinous histology, right. Now other markers, a panel of markers are to be done in the reproductive age group female. Okay, whenever we have reproductive age group female or a premenarcheal female, right, we have a panel of markers to be done. So important thing to remember is, let us see the markers and let us see this thing. Okay, so let us see immature teratoma is malignant, and immature teratoma, or a dermoid for that matter, or teratoma of any kind, there is no specific marker. There is no specific marker for this. Then there is dysgerminoma. Dysgerminoma is the most common germ cell tumor. Dysgerminoma, the marker is LDH. The main marker of dysgerminoma is LDH, all right. Question was asked, all are markers except. For dysgerminoma, all are markers except. So remember, never AFP. Never AFP. AFP is never a marker of dysgerminoma. So LDH is a marker. Then after that, placental alkaline phosphatase is a marker. HCG can also be a marker. Means HCG is also raised, placental alkaline phosphatase is also raised. LDH is the main marker if you have to choose one, but it is never AFP. AFP, on the other hand, is a marker for endodermal sinus tumor. Endodermal sinus tumor, the marker for endodermal sinus tumor is AFP, all right, more than LDH. So the main marker is AFP. Then we have the next, which is the embryonal cell carcinoma. It has both HCG and AFP as markers. And choriocarcinoma, this choriocarcinoma is different from the gestational choriocarcinoma. The marker for this is HCG. Okay, so these are about the cancers. Then another important marker, if you say granulosa cell tumor. There is granulosa cell tumor. Granulosa cell tumor, the marker is inhibin. Very, very important. The marker for granulosa cell tumor, if they ask you the marker is inhibin, but it also secretes, granulosa cell also secretes estradiol. Okay, but estradiol is not a marker. The marker is inhibin. Granulosa cell tumor also secretes estradiol. So if they ask you the ovarian tumor that is associated with endometrial cancer, okay, then it can lead to abnormal uterine bleeding, it can lead to your precocious puberty, right? It can lead to dysfunctional uterine bleeding, it can lead to endometrial hyperplasia, it can lead to endometrial cancers, right? So this granulosa cell tumor, because it produces estradiol, it can lead to all these things, all right? Now granulosa cell tumors histologically also they contain Call-Exner bodies. Call-Exner bodies on histopathology are also seen in granulosa cell tumor. Then we have the virilizing tumors which secrete androgens. They are the theca cell and the Leydig cell tumors, okay? Theca cell and the Leydig cell tumors, which are the virilizing tumors which secretes androgens. So this much you should know about the markers of ovarian cancer, right? Then they ask this question sometimes that what is the histopathologically important point in the borderline tumors? Borderline ovarian tumors, there's another variant which is the borderline ovarian tumors. Question has been asked in recent times on borderline ovarian tumors. So these are tumors of low malignant potential, they are slow growing. Women is in the 30s to 50s age group. Very important point to remember, there is absence of destructive stromal invasion. Okay, that is the histopathological finding, absence of destructive stromal invasion. All right, so this is an important point to again to remember about the various. So we've discussed the various histopathological and the markers of these ovarian cancers. All right. Now let us move on to the next question. (43) we have done with rheumatic heart disease. This question also we have done. 45 we have done. 46. Let's come on to question number 46. Question number 46. All right, question number 46. The most common cause of vesicovaginal fistula in India is obstructed labor. Obstructed labor is the answer. In outside countries, you know, in Western countries, the common cause of vesicovaginal fistula is gynae surgeries, okay, is hysterectomy, not obstructed labor. So let us just talk a little bit about the vesicovaginal fistulas and the gynae abnormalities. All right, so let us talk about the important points, because this topic is sometimes asked. So I just want to give you the very basic details of what is asked sometimes in these questions, the important points. Vesicovaginal fistulas. Now vesicovaginal fistulas they can be obstetric, which are the most common types in India, and in obstetric they will happen because of obstructed labor. Usually what happens after the obstructed labor, there is ischemic damage. All right, there's ischemic damage and sloughing that leads to the vesicovaginal fistulas. And then in the developed countries, the etiology is hysterectomy. Okay, hysterectomy surgeries which leads to the vesicovaginal fistulas. So when this when the gynecovaginal fistula is post hysterectomy surgeries, then these fistulas are usually smaller, and when they occur because of the obstetric or obstructed labor and the ischemic damage, so ischemic damage usually involves a very sloughing off of a large area, right? So they are usually larger. So they are usually larger. So these smaller fistulas, they are usually treated by the Latsko repair, and these larger fistulas, they are usually treated by the Chesamoid technique. This is one thing to remember, right? And the only difference between these two techniques basically is obviously when the fistulous tract is removed and then the bladder is stitched separately and the vagina is stitched separately. What you have to remember in the Latsko repair, the fistulous tract is not excised. That is the difference. Fistulous tract is not excised, whereas in Chesamoid technique it is excised. So just one important bit that has been asked in questions sometimes, that where this Latsko repair is done, where the Chesamoid technique is done, that is to be remembered. All right. Now once they also ask this question that vesicovaginal fistulas, whenever the fistula repair surgery is done, the site, the local site should be free from infection to have the integrity of the repair maintained. So it is very important to have a sterile urine culture, right? Sterile urine culture before proceeding with this surgery. So the question that was asked, that how to obtain urine sample, right, or how to obtain urine sample, the best method, because the urine is pooling in the vagina and there is continuous dribbling. So the best method is basically by doing a Foley's catheter, via a Foley's catheter. That is the best method to obtain a urine sample. The best method would ultimately mean the most sterile method to obtain urine sample is via a Foley's catheter. So this question was asked there. Then other questions that are asked are about the 3-swab test. Okay, about the 3-swab test. So another important point about the 3-swab test, let's suppose that this is the vagina, and this is this thing, and this is the bladder. Okay, this is the bladder and this is the vagina. 3 swabs are kept here. Okay, 3 swabs are kept here. So they say that there is one fistula here and then there is another fistula here, right? So this is the topmost, let's say this is 1, 2 and 3, all right? So if they ask you, if they say that only the bladder is filled with methylene blue dye, and then the staining of these swabs are seen, all right? Now this 3-swab test is used when the fistulas are very small and one cannot see what kind of fistula it is or where the fistula is actually located, and we can do this test, a 3-swab test. So if the first swab is stained and the first 2 and 3 are dry, all right? So let's say that if the first swab is stained blue, all right, the second swab is disregarded because it can be stained. So first or second stained blue and the third is dry, then it is a VVF, vesicovaginal fistula, right? Similarly, if the third is stained blue and the second by diffusion and the first one is dry, then it is a urethrovaginal fistula, right? Then the other situation is that all three are stained, all three are wet with urine, but none is stained, not stained, right? Then it is a ureterovaginal fistula. Then it is a, okay, let me write it here. If all three are wet with urine and they are not stained, then it is a ureterovaginal fistula. All right, so this is the important bit to remember here about the 3-swab test. All right, so sometimes this question is also asked about the 3-swab test, where we can do the but what you have to remember that the final evaluation for a vesicovaginal fistula, which is vesicovaginal fistula, should be done for a small fistula which cannot be seen, should ideally be done by a cystoscopy. Examination of the bladder, this is done ideally. Final evaluation would be done by this. All right. Then there are certain times this, let me just talk about the ureter injuries, the various ureteric injuries in gynae surgeries, and let us just talk about the basic important points here. That first of all, first important point to remember about ureteric injuries in gynae surgery, the most common site, right? So the most common site involved is that 1.5 centimeters lateral to the cervix, where uterine artery crosses over the ureter. This is the most common site, right? The second most common site is the pelvic brim. Where the ureter crosses over the bifurcation of common iliac artery. All right. So the most common site is the site where the uterine artery crosses over ureter, and the second most common site is the pelvic brim. All right. Now another important point to remember is the most common surgery. When they ask you what is the most common surgery associated with ureteric injuries, then the answer is abdominal hysterectomy, okay, or basically simple hysterectomies, okay, because simple hysterectomies are done more in number. But if they ask you, okay, if the question is just asking most common surgery which is associated with ureter injury, the answer is abdominal hysterectomy, right? But they specifically ask you which surgery has maximum risk. All right, these are two different things. All right, one is asking which is the most common surgery, that is abdominal hysterectomy, simply because abdominal hysterectomies are done more commonly. But if they ask you which surgery has maximum risk of ureteric injury, then the answer to this would be a Wertheim's hysterectomy, because Wertheim's hysterectomy needs more extensive dissection. So obviously Wertheim's hysterectomy is the surgery which has maximum risk of ureteric injury. All right. So this much you have to understand. These are the 4 important points about ureteric injuries that you should remember in gynae surgeries. All right. Now let us move on to the next question. The next question is question number 47. Risk of HIV transmission is highest during. Now the risk of HIV transmission is highest during which period? During cesarean section, during antepartum period, during vaginal delivery, or during breastfeeding. So the highest risk is during vaginal delivery. All right. So this question can again be asked in various ways. HIV transmission is highest. Basically, HIV transmission is highest during the peripartum period. All right. So in other words, peripartum period. Peripartum period is the period which is all right. So risk is highest risk during the peripartum period. Peripartum is the period which is involving the last few days plus labor. All right. So that is the peripartum period. if peripartum period is in the option, that is the answer. All right. Here peripartum period is not in the answer. There's antepartum period. If this option, if the question had peripartum period as an option, that would have been your answer. All right. Vaginal delivery is the second, the next in line, next answer choice. Your next choice would be the intrapartum period. That is during delivery. Right, so during vaginal delivery, next answer is your intrapartum period. All right. So this is an important point to remember. Then another important point to remember is about, what about cesarean sections? During cesarean section also, cesarean section, in fact cesarean section is used as a method to decrease the risk of HIV transmission. All right. So Western countries, what they do elective cesarean sections when the viral load is undetectable or it is very, very low. All right. There are various guidelines. The Americans do it differently. The UK people, they do differently, have different guidelines to offer vaginal versus cesarean as a mode of HIV risk transmission. In our country, in India, the NACO says, the NACO guidelines state that basically what are the recent NACO guidelines regarding the HIV prophylaxis or whatever HIV prophylaxis in pregnancy, regarding the NACO guidelines in pregnant female. Important point is that whenever a pregnant female is diagnosed as being HIV positive, she is obviously, any HIV positive woman in pregnancy, she is first of all referred to an ART center, and integrated ART center, integrated services should be given. An important point to remember is that she is initiated antiretroviral prophylaxis irrespective of her CD4 counts. First of all, she's initiated ARV prophylaxis irrespective of her CD4 counts. All right. So it doesn't mean that CD4 counts are not done. CD4 counts are definitely done to prognosticate, but ARV prophylaxis is initiated irrespective of the initiated counts, CD4 counts, and then this should be continued lifelong. All right, so she starts ARV prophylaxis, and the therapy of choice here is 3-TC plus tenofovir, 3-TC is lamivudine plus tenofovir plus efavirenz. Okay, so earlier, another important change is that earlier efavirenz is used to be thought that it is teratogenic. Now efavirenz can be given, this is the drug of choice, this is the treatment of choice. This comes in a single dose, this comes as a single dose combination, this comes as a single dose combination. An important point to remember is that efavirenz can be safely given in first trimester. Earlier it was said that in the first trimester change to nevirapine, but now not so, it can be safely given in the first trimester. So these are the important bits, right? Second important bit is that whenever such a woman goes into labor, all right, whenever such a woman goes into labor, what happens is that we continue the same treatment, and then the child, okay, the infant is given nevirapine till 6 weeks. Okay, infant is given nevirapine till 6 weeks, and the mother obviously is continuing lifelong, she is continuing even in the postpartum period. All right, so this is, she continues even in postpartum period, she continues lifelong, even postpartum, lifelong, and infant is given nevirapine till 6 weeks. Okay, and exclusive breastfeeding in our country, exclusive breastfeeding is advocated. So we do not contraindicate breastfeeding. If a woman chooses to do no breastfeeding, then she should be counseled to avoid mixed feeding. Okay, if it either has to be exclusive breastfeeding or exclusive replacement feeding, all right, but it cannot be a mixture of the two. All right, so it cannot be a mixture of the two. There is no mixed feeding. It cannot be a mixture of the two. It has to be either exclusive breastfeeding or exclusive replacement feeding. So breastfeeding is not contraindicated in developed in our country, in developing countries here. And another important thing is that we do not offer elective cesarean sections. All right, we start the ARV prophylaxis, and in our country we do cesarean for obstetric indications, cesarean for obstetric indications. All right, because there is no point that you do a cesarean for HIV. So basically what I want to come to that is the route of prophylaxis of mother to child transmission, that has to be complete. So whenever you do one intervention, whenever you do any intervention, it has to be complete. Like for example, initiate ARV prophylaxis, right? Then do elective cesarean section, and then do contraindicate breastfeeding altogether, right? So all stages have been attacked. That is what the Western guidelines, the American and the UK guidelines write, right? That they give ARV prophylaxis, they also do elective cesarean sections, and they also contraindicate breastfeeding. There is no point doing an elective cesarean section and then allowing to breastfeed. Right, then whatever advantage that was gained by doing an elective cesarean section is counteracted by allowing to breastfeed. All right. So in other words, therefore in our country they say that we should give NACO says that do cesarean, the National AIDS Control Organization in their guidelines they mention cesarean section for obstetric indications, and exclusive breastfeeding is advocated. There should be no mixed feeding. Although a woman can choose to have an elective cesarean section, and then she should also be advised about exclusive replacement feeding. All right. So this is about the HIV prophylaxis in pregnancy. Now let us move on to the next question, question number 48. All right. A primary gravida with 36 weeks of pregnancy is in labor with 3 centimeter dilatation and minimal uterine contractions. On rupture of membrane, fresh bleeding is noted and late fetal decelerations of up to 50 beats per minute. So fetal heart rate has drastically reduced. All right. The patient was taken for LSCS, but the fetus could not be, oops, it's up. The fetus was taken for cesarean section, but the fetus could not be saved. No abruptio or placenta previa was seen. The likely diagnosis is, right? So placenta previa is not there, they are saying that there was no abruption, but the diagnosis here is vasa previa. The diagnosis here is vasa previa. Why? Because this is, why is it not revealed abruption? It is not revealed abruption because the symptomatology, the clinical picture that has been described in this question is classic of a vasa previa, right? Because what is clinching the diagnosis about vasa previa? The fact that the fetal heart rate dropped just at doing the just when the membranes were ruptured. That means just when the membranes were ruptured, something happened that led to fetal heart rate deceleration, and that too a deceleration which did not improve and led to death of the baby. That means that all that bleeding that was happening at that point in time was all fetal. From all these situations, the one situation where the bleeding is fetal is vasa previa. So what is vasa previa? Vasa previa is when the vessels are overlying, when the fetal vessels are overlying the internal os, right? And most of the times this situation of vasa previa is associated with a velamentous cord insertion. What is velamentous cord insertion? Velamentous cord insertion is when the umbilical cord is attached to the membranes rather than the placental bulk. All right. So supposing that this is the uterus, this is the os, these are the membranes here, this is the baby's head here, right? And this is the amniotic, these are the amniotic fluid, amniotic membranes, and this is the placenta. Sometimes the placenta is here. This is the placenta, right? And the umbilical cord is attaching to the membranes, right? This is the placenta and the umbilical cord is attaching to the membranes. Umbilical cord is attaching to the membranes rather than to the center of the placenta. It is not attaching here where it is usually, it is attaching to the membranes. So when these membranes are ruptured or they shear off, the bleeding is all fetal with vasa previa, right? So with bleeding vasa previa, remember that with bleeding vasa previa, the bleeding is always fetal. There is a fetal blood loss which can lead to severe bradycardia and death of the fetus also. So that will lead to this classical picture, clinical picture that has been described is inconsistent with vasa previa. Let us move on to the next question. All right. A 2-hour-old neonate born by normal vaginal delivery has a scalp swelling with normal cry and activity. All right. So this 2-hour-old neonate baby after vaginal delivery has this scalp swelling. What can we appreciate in this figure about the scalp swelling? That it is somewhere here. It is in the center. It is crossing the suture lines, and the baby is otherwise normal cry and activity. So nothing very significantly ominous in the baby's condition, right? So what is this most likely situation? This is the very common location of a very common thing that happens in normal vaginal deliveries, that is called as caput succedaneum. Now this caput succedaneum is actually scalp swelling, right? And it is edema in the vessels of the scalp. So this is nothing but an edema in the vessels, that is why, edema in the layers of the scalp, edema in the layers of the scalp. So that is why it is a serosanguinous extraperiosteal fluid. Extraperiosteal. If it is a subaponeurotic blood collection, then it is a cephal hematoma. This subaponeurotic is a cephal hematoma. Chignon is also swelling, but that chignon is seen typically with vacuum application. And if it had been a depressed skull fracture, the baby would not have been normal. So these two can be excluded out directly. Focal subaponeurotic blood collection also, if the fetus is losing blood and it is subaponeurotic, then it would not have crossed the suture line. So remember the differences, this differences between the caput succedaneum. Remember these differences between caput succedaneum. The differences between caput succedaneum and the differences between cephal hematoma. All right, caput succedaneum is above the periosteum. It is in the layers of the scalp. It is an edema in the layers of scalp. Very importantly, since it is above the periosteum, it crosses the suture lines. Cephal hematoma is on the hand below the periosteum, right, caused by bleeding from the vessels, underlying vessels, but cephal hematoma, it is below the periosteum. It is a subperiosteal swelling, and therefore it is limited by suture lines. It does not cross suture lines. Importantly, caput succedaneum is visible immediately after birth, and it subsides actually in 3 to 4 days and usually does not lead to any symptoms. Cephal hematoma, it increases basically in the first 3 days, and it may not be evident immediately after birth because it takes some time to grow after bleeding happens, right? So it increases in the first 3 days, it will not be evident, and then it subsides also on its own. So basically both of these situations, sometimes they have asked this question that a baby has cephalhematoma. A baby has cephalhematoma and the baby is otherwise well, okay, otherwise doing well, otherwise active. What is the treatment? The treatment is not to drain this hematoma. The treatment is observation, because most of the times it is going to subside on its own. All right. At the most, while resolving this cephalhematoma, can lead to jaundice, it can lead to anemia, and so that is what the observation has to be done for jaundice and anemia. And if it becomes significant and troublesome, then these two conditions are treated. But this cephalhematoma, important point is that it is observed, it is not drained. Okay, similarly, caput succedaneum is also managed conservatively because it is just a edema in the layers of the scalp. It usually subsides in 3-4 days. The baby is also otherwise active and healthy most of the times. All right. Now moving on to the next question. Question number 50. Fallopian tube dysmotility is seen in, the answer is cartilaginous syndrome. Cartilaginous syndrome is a disorder, is a disorder. It is an inheritable disorder. It is a heritable disorder where the cilia are affected in so many tracts, in the reproductive tract, in the respiratory tract also, right? So it is one disorder where cilia are affected in the respiratory tract, as well as in the in the reproductive tract. So basically this is where there is fallopian tube dysmotility, because fallopian tube has got ciliated epithelium, ciliated columnar epithelium. An important point to remember about fallopian tube cilia, on which question is asked sometimes, that the ciliated columnar epithelium, the fallopian tube is not ciliated throughout. Okay, it is not ciliated throughout. There are sometimes there are cilia, and some patches there are not, there are no cilia. So ciliated epithelium, but it is not ciliated throughout. Another important point about fallopian tube motility they have asked is that for the movement of conceptus, in the tube, these cilia are very important. All right, but for the movement of conceptus, the main is tubal peristalsis. Okay, main is tubal peristalsis, and then second is your cilia beating. Okay, cilia, the beating of the cilia in the direction of the uterine cavity comes as the second point, right? So for the movement of conceptus, both contribute, but the main is tubal peristalsis. All right. Let us move on to the next question. Question number 51. Which of the following is not effective in treatment of hot flashes? Well, the answer here is tamoxifen. Tamoxifen is a selective estrogen receptor modulator. All right, it has estrogen-like activities, agonistic activities in certain areas, certain tissues, and antagonistic action in certain tissues. Tamoxifen was introduced for the treatment of endometriosis, for the treatment of breast cancer. So on breast, actually, what happens? You have to remember that tamoxifen was used for breast cancer, so it has antagonistic actions on the breast, but it has agonistic actions on the endometrium, so it can lead to endometrium hyperplasia. Other important point is that it causes hot flashes as a side effect. It causes hot flashes as a side effect. Hot flashes are also caused by raloxifene, also causes hot flashes. All right, it is the another side effect of tamoxifen is venous thromboembolism, is also a side effect. All right. So in case of hot flashes, in case of menopausal women with hot flashes, in case of menopausal woman with hot flashes, remember, with menopausal women with hot flashes, the treatment is HRT, hormonal replacement therapy. If the uterus is present, then the treatment has to be estrogen plus progesterone. If the uterus is absent, we can use estrogen alone. All right, because estrogen plus progesterone is a risk for, with estrogen plus progesterone, especially the progesterone component, there is risk for invasive breast cancer. Okay. Another important point is if uterus is absent. Now, if estrogen is contraindicated, example, there is history of venous thromboembolism, there is history of stroke, there is multiple cardiovascular risk factors, right? So, all these are absolute contraindications of estrogen. Then if estrogen is contraindicated like venous thromboembolism or history of stroke, and you have to give HRT for hot flashes, then one can give SSRIs, okay. In that we have the venlafaxine and the paroxetine, the other options, all right. So this is about the menopausal treatment with hot flashes. If there is a menopausal woman, menopausal women with vaginal dryness, okay, for vaginal dryness, what do we give? For vaginal dryness, we give local estrogen cream. Okay, the treatment of choice is local estrogen cream for vaginal dryness. For decreased libido associated with menopausal symptoms, menopausal women with decreased libido, we can give androgens. The androgens is the treatment of choice, right? With osteoporosis. Right, with osteoporosis, when the treatment for osteoporosis is bisphosphonates, okay, the treatment for osteoporosis is bisphosphonates, but HRT is not treatment for osteoporosis. Remember, HRT is not treatment for osteoporosis. HRT is preventive for osteoporosis, okay. HRT is preventive for osteoporosis. So in effect, we have HRT is preventive for osteoporosis. Then other important factor is there is a new there is a basdoxephin plus ethinyl estradiol. All right, we can use ethinyl estradiol plus basdoxephin. This is also an SERM, but the important point is that this can help in treatment of hot flashes, and this will also be protective for bones. And the advantage that it is gained here, this is here. Okay, so basdoxephin plus ethinyl estradiol can be used, is a new agent that has been approved. This is a new SERM which has been approved, but it has to be used with ethinyl estradiol for the treatment of hot flashes, and it is also protective for the bones. Now let us move on to the next question. Question number 52. The contraceptive of choice, which is the contraceptive device which is shown here, is, now this is a cylinder here, no problem in identifying this. This is a this is a Mirena. Not Progestasert, sorry, this is Mirena. The answer is B. Progestasert is no longer available in the market. This here image is a multi-load. And okay, so Mirena. Copper T on the other hand has got wound round brown like this copper. On the other hand, copper T would have been copper here on the stem and also on the limbs. also on the limbs. That would have been copper T. So this is Mirena basically, and when we talk about Mirena, let me just give you a very comprehensive, let me give you one flow chart which will answer your Mirena and copper T woos. Basically, let us just do both our what when we study contraception, we study these days, we study contraception. When we say the questions that are asked sometimes is what is LARC? What is LARC? LARC is long acting reversible contraception. Okay, long acting reversible contraceptives, these are LARC. All right, so what are included in this LARC? Okay, what are included in this LARC is your copper T 380A, Mirena, implants. Okay, these will be in my top 3 choices. Okay, because copper T 380A is effective for 10 years, Mirena lasts for 5 years as contraceptive, implants last for 3 years. So these are all long acting, right? Then the fourth, which will be my last choice, because certain books and certain authors write it as a LARC, certain authors do not write it as a LARC. So top 3 choices of long acting are this. Then last will be DMPA. DMPA injection has to be given every 3 months, right? This is also called as depomedroxyprogesterone, Depo-Provera. The new thing about this DMPA injection is that now it will be available by the Ministry of Health and Family Welfare as free, and this will come under the trade name of Antara, being marketed, being publicized as as Antara. Okay, so this is what is important here. So when we talk about, let me just give you a few comparative bits about copper T. Let us do copper T 380A and Mirena, concentrate on copper T 380A and Mirena. So talking about copper T 380A and Mirena. Mirena is an levonorgestrel containing IUD. Important points of differences to remember is, first of all, importantly, what is the mechanism of action? When we come on to the mechanism of action of copper T and 380A, first of all, remember both do not inhibit ovulation. Okay, both do not inhibit ovulation. So these are 2 methods which do not inhibit ovulation, yet they have a very good efficacy. Now the mechanism of action of copper T 380A is inhibition of fertilization is the main mechanism, and then is inhibition of implantation. Okay, so the main mechanism is inhibition of fertilization, because the copper ions, they are spermicidal, they are toxic to the sperms. Okay, second important point is with Mirena. Mirena basically causes endometrial atrophy. Okay, it makes the endometrial so thin, so unreceptive that it inhibits implantation. So Mirena has nothing which will be toxic to the sperms. All right, so it will not inhibit fertilization. The main mechanism of action with Mirena will become inhibition of implantation. However, both of these, they do not inhibit ovulation. Okay, as far as the lifespan is concerned, the lifespan with copper T 380A is 10 years. With Mirena, you have to remember that as a contraceptive, the lifespan is 5 years. The recommended use is for 5 years, but it keeps releasing the drug. Till 7 years, okay, till 7 years, but in smaller quantities, right? So Mirena contains how much of, another question that they ask is how much does it contain? It contains 52 milligrams of levonorgestrel, which is released at the rate of 20 micrograms per day. This is additional point that is asked about Mirena. So when we have talked about the mechanism of action, we have talked about the lifespan. What else about Mirena and Copperty? Copperty and Mirena, 380A and Mirena, the failure rate. The failure rate of Copperty 380A is 0.6 to 0.8%. With Mirena, the failure rate is 0.2%. So we see that Mirena, in other words, Mirena is as effective as tubal sterilization. Okay, Mirena is as effective as tubal sterilization. This Mirena has a failure rate of 0.2%. Importantly, Copperty can be used as an emergency contraception. Okay, Copperty can be used as an emergency contraception. Mirena, on the other hand, is not used as emergency contraception, remember. Not used in emergency contraception. Another important point is that Mirena, on the other hand, is useful in abnormal uterine bleeding. Okay, Mirena is useful in abnormal uterine bleeding because in 30% of these women, Mirena causes, decreased bleeding, and in another 30% of these women, Mirena causes amenorrhea in 2 years. So it is very effective because it thins the endometrium so much. This is it. But so it is useful in treating abnormal uterine bleeding. But with Copperty, the problem is that the most common side effect with Copperty is abnormal bleeding or excessive bleeding. But the most common cause of removal of Copperty is pain. Okay, so most common side effect with Copperty is abnormal bleeding. Most common cause of removal is pain. Alright, most common cause of removal is pain. So this is important, and if we talk about Mirena, the most common side effect of Mirena is irregular vaginal bleeding. Sometimes spotting. Specifically, there is no pattern, irregular vaginal bleeding. This irregular vaginal bleeding is because of the progestational effect. So all these progestational contraceptives like your Mirena, like your DMPA, like your progesterone only pills, all these progesterone only contraceptives, all of them, be it implants also, because we have progesterone implants, right? Implanon is a progesterone implant. So all these progesterone only contraceptives, be it Mirena, be it progesterone only pills, be it DMPA or injectable, be it implants or implanon, all of them, they have one most common side effect, which is irregular vaginal bleeding. Okay. So this is about your Copperty versus Mirena. All right. Now identify the instrument given in the figure below. This instrument is a Rubens insufflation cannula. Alright, this is a Rubens insufflation cannula. Right now it is no longer used most of the times. This instrument is used to